Oh, I'm so excited by this. So one of the issues we are facing is the amount of training it takes for CBTI and for PTSD. So the best evidence-based treatments for PTSD are going to be for long exposure, EMDR, eye movement reprocessing desensitization, and cognitive processing therapy. So those are our gold standards. The amount of training that it takes for anybody, clinician, to get those, it's substantial, and it's important. But because of that, you have a filter by the number of providers, by the number of people who have trauma and PTSD. And we see it at the VA hospital where we have 1,000 individuals waiting for one-on-one treatment. But also the providers and the community, right? It's not going to fix it. And so the question is kind of what can we do to maybe not cure, maybe not fix it, but give them some stability with a remote ambulatory system. And so the premise is, can we give them something that will help them in the meantime until they can see that one-on-one person?
So yeah, for a long time we've known that having a narrow, collapsible upper airway is a major cause of obstructive sleep apnea, and most of the treatments have focused on mechanically trying to open up that airway and improve it. Things like continuous positive airway pressure therapy, oral appliances, and multi-level upper airway surgery all try to attack that impaired upper airway anatomy cause. But in more recent years, we've learned about the non-anatomical causes, things like impaired upper airway muscle function. So the pharyngeal dilators, we've got these about 25 pairs of muscles around the upper airway from the back of the throat to the back of the nose. And that's the collapsible portion of the airway. And when those muscles don't activate enough as we go off to sleep, that can contribute to sleep apnea. And two of the other non-anatomical factors are things like arousal threshold. And that's really to do with how easily you wake up to a little bit of airway narrowing when we go off to sleep. We all get a bit of airway narrowing. And if some people are just particularly sensitive to that, and being a light sleeper or having a low respiratory arousal threshold is a problem for about a third of people with sleep apnea.
Dopamine agonists were first approved for restless leg syndrome almost 20 years ago. And there has never been any question about whether they're effective for restless leg syndrome or not. They're really wonderful. Problem is they're wonderful in the short term. For maybe half of people, over time, symptoms of RLS worsen. It certainly doesn't happen in the first few weeks or months, may not even happen in the first few years. We think somewhere around 7 to 9% of people will develop what is called augmentation of RLS symptoms, a worsening of the underlying problem.
So our study find that some napping patterns were associated with increased all-cause mortality in middle to older aged adults. We did not specifically examine each specific cause of death, and I think that's great direction for future research. In terms of the strength of the associations, they were statistically significant, but relatively small in magnitude, meaning that napping patterns only explained a small proportion of mortality risk. And it's important to note that our study is observational, and what we found were associations, not causation. So in other words, we found napping behaviors to be linked with mortality risk, but we cannot conclude that napping causes mortality.
Well, I think the main thing to keep in mind and why this is so exciting is this is a first in class drug to treat obstructive sleep apnea, really targeting neuromuscular tone. Uh, that is, really transformational. And then the other thing is that we have met our primary endpoint. So that's why it's important. And then the third thing is the population that we studied is very diverse, and we'll be able to get some very good insights in how this drug could be used to help patients.